Assalamualaikum. My name is Maham Latif and the topic of my presentation is Geriatric Urological Disorder and subtopic is Sexual Dysfunction. Sexual dysfunction is also called impotence is a type of sexual dysfunction in which the penis fails to become or stay erect during sexual activity. It is the most common sexual problem in men through its connection to self-image and to problem in sexual relationship. Erectile dysfunction can cause psychological harm. I will cover management and pharmacotherapy. Essentially, there are three levels to the management of erectile dysfunction. Level 1, mandate lifestyle and drug therapy modifications. Specifically, the patient should be instructed to modify smoking and alcohol use. The patient's drug regimen should be checked periodically to ensure that drugs associated with erectile dysfunction are not being prescribed. If necessary, psychosocial counseling should be provided. After careful consideration, oral medication for management of erectile dysfunction should be instituted. If level 1 therapies have been failed or are not acceptable to the patient, then level 2 therapy is instituted. These interventions include vacuum constriction device to elicit an erection, intracavernous injections or transurethral inserts. Level 3 management involves placement of penile prosthesis. Pharmacotherapy. Any therapy directed at male sexual dysfunction must include the elimination of drugs causing adverse sexual effect. Drug therapy is directed primarily toward treatment of erectile dysfunction and includes hormonal therapy, bromocriptine, yohimbine, prostaglandin, sildenafil, tadalafil, vardenafil, and apomorphine. Testosterone. Primary hypogonadism with severe deficient serum level of bioavailable testosterone is the only appropriate indication for the use of androgen hormone therapy. The goal of androgen replacement therapy is to restore potency and libido by maintaining normal serum level of testosterone. Testosterone has no benefit in the treatment of eugonadal or mildly hypogonadal elderly men and actually may enhance the growth of undiagnosed adenocarcinoma of prostate or cause further erectile dysfunction. So testosterone therapy is not for the elderly man. Unless testosterone deficiency is severe, for example, if free testosterone serum levels are less than 7 to 8 pg per ml, testosterone replacement therapy will not improve the success rate of intercourse. Testosterone replacement in patients with primary hypogonadism generally restore libido and potency. In some patients with secondary hypogonadism caused by disorder of the hypothalamus and pituitary, gonadotropin releasing hormone analog can be administered to differentiate between the hypothalamic and pituitary abnormalities and to correct testosterone deficiency. Libido and potency then are restored. How should testosterone be used? Testosterone replacement therapy is available in several formulations including gels, topical bodies, scrotal patches, and intramuscular injections. Because of poor drug bioavailability, oral testosterone replacement therapy is less effective than parenteral testosterone in achieving normal serum testosterone level. Oral administration is also associated with the higher incidence of hepatotoxicity and adverse serum lipid effect. Bromocriptine. Hyperprolactinemia may be treated with the ergot alkaloid bromocriptine. Normalization of the serum prolactin level is mandatory if potency is to be restored. Even with the normalization of prolactin level, approximately 50% of the elderly male patients are unable to achieve erectile function and desire. Bromocriptine therapy may be initiated with twice daily 1.25 mg doses taken with the meal to minimize gastrointestinal upset. Thereafter, doses may be increased weekly at a rate of no more than 2.5 mg per day. Because bromocriptine is associated with dizziness, drowsiness, hypotension, and cerebrovascular accident, the patient should be forewarned. Sildenafil. Sildenafil citrate is an orally active and selective inhibitor of CGMP specific phosphodiesterase type 5, the predominant phosphodiesterase isoenzyme metabolizing CGMP in the corpus cavernosum. Sildenafil facilitates an erection in response to sexual stimulation by enhancing the nitric oxide-induced relaxation of corpus cavernosal smooth muscle. The results of double-blind placebo-controlled clinical trial in men with erectile dysfunction of various causes have been demonstrated that the sildenafil significantly improves erectile function and the rate of successful sexual intercourse, with therapeutic outcome approaching those of normal men of the same age. The typical dose of sildenafil is 50 mg orally taken 1 hour before sexual activity. Tadalafil, similarly to sildenafil, tadalafil is selective inhibitor of phosphodiesterase 5. Tadalafil have several times more affinity for phosphodiesterase 5 than sildenafil. The clinical significance of this increased affinity for phosphodiesterase 5 is unknown because comparative clinical trials between the phosphodiesterase 5 inhibitor sildenafil, tadalafil, and vardenafil have not been conducted. Tadalafil is metabolized by the hepatic CYP isoenzyme. Food has no effect on oral absorption of tadalafil in contrast to sildenafil. Bioavailability decreased by 29% in sildenafil. Tadalafil may be advantageous in subset of patients based on its shorter onset of action and 24-hour duration of action. Specifically, patients with psychogenic and neurogenic erectile dysfunction are those with stable cardiovascular system and may prefer tadalafil because it offers the potential for multiple sessions of intercourse encounter with a single daily dose. Vardenafil is the third FDA-approved oral phosphodiesterase 5 inhibitor for treatment of erectile dysfunction. Vardenafil, as with the other phosphodiesterase 5 inhibitor, has an affinity for phosphodiesterase 6 and will therefore cause ocular adverse effect. The warning regarding the use of nitrates while taking vardenafil are similar to the warnings for sildenafil. Patients using vardenafil may experience headache, flushing, or rhinitis. The incidence of these side effects are dose related. Vardenafil 10 mg dose does not impair the ability of patients with stable coronary artery disease to exercise at levels equivalent to or greater than that attained during sexual intercourse. Yohimbine. Yohimbine hydrochloride is an alpha-2 adrenergic antagonist that decreases the outward blood flow from the penile corporal tissue. The effectiveness of yohimbine relies on an adequate penile blood supply. It has been used in treating erectile dysfunction among diabetics with some degree of success. In some patients, yohimbine have been associated with nausea, tachycardia, a slight elevation in blood pressure, anxiety, and panic attacks. Intra-cavernous injection. In 1982, inadvertent injection of papaverine into the penis was found to produce an erection. This landmark observation ushered in a new methodology for diagnosis and therapy of erectile dysfunction. By 1986, papaverine injection into the penis had gained worldwide popularity for the treatment of erectile dysfunction. In 1986, the alpha blocker phenoxybenzamine also was noted to be effective. Shortly thereafter, the combination of papaverine with another vasodilator, phentolamine, reportedly enhanced and prolonged erection duration. Papaverine-phentolamine combination. Papaverine, a non-specific phosphodiesterase inhibitor, increased the serum concentration of cyclic AMP, resulting in penile, arteriolar, and corporal sinusoidal smooth muscle relaxation. Papaverine also may relax an elastic venous valve mechanism that is kept open by adrenergically mediated smooth muscle contraction. Phentolamine exerts its relaxant effect by alpha-adrenergic receptor blockade of both alpha-1 and alpha-2 adrenoreceptors. In addition, phentolamine also may have a direct, non-specific relaxant effect on vessels. The combined use of papaverine with phentolamine exerts a greater effect that would be experienced with either drug alone. Candidate for intracavernous injection therapy. Patients who have failed to obtain a satisfactory erection while on oral drug therapy such as sildenafil, tadalafil, yohimbine, or sublingual apomorphine are candidates for intracavernous injection of vasoactive drugs. The patient must have a complete medical workup to include assessment of penile arterial system. Doppler sonography of the penis identifies penile architecture, defines the thickness of any plaque, measures the diameter of cavernous arteries before and after vasodilation, and allows visualization of penile arteries. The non-invasive assessment of individual penile arteries is much more accurate than penile brachial pressure index (PBI). Now, case study: a 66-year-old man was referred to a urologist because he was experiencing a loss of interest in sexual activity. He describes the inability to maintain a firm erection for past 6 months in more than 75% of sexual attempts with his sexual partner. There are conditions. Uh, What signs and symptoms does have that would suggest the need for complete medical workup for erectile dysfunction? डायग्नोसिस: पेशेंट जो है उसे हाइपरटेंशन है, डायबिटीज़ है और इरेक्टाइल डिस्फंक्शन है पिछले 6 माह से, और जो पेशेंट है वो स्मोकिंग भी करता है। सबसे पहले ट्रीटमेंट में ये आएगा कि पेशेंट को अपना लाइफस्टाइल चेंज करना चाहिए, स्मोकिंग को छोड़ना चाहिए ताकि हाइपरटेंशन कंट्रोल हो सके। और एक बड़ी वजह है इरेक्टाइल डिस्फंक्शन की स्मोकिंग। और इसके अलावा जो पेशेंट अभी करंटली जो मेडिकेशंस ले रहा है उसका कोई इफ़ेक्ट नहीं है, कोई लिंक नहीं है इरेक्टाइल डिस्फंक्शन से, तो वो मेडिकेशंस कंटिन्यू कर सकता है। और ड्रग ऑफ चॉइस जो है इस पेशेंट के लिए वो सिल्डेनाफिल है, 50 mg orally 1 hour before sexual activity according to his condition. Or patient should have sonography combined with Doppler analysis to assess the adequacy of his penile arterial blood flow. And other than that, the abnormal level of hormones is due to the age factor. This is all about my presentation. Thank you. Allah Hafiz.